Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's Career Center, offering career resources, free resume reviews, and personalized job alerts, with information available at www.aacn.org/Career Center. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. This is Dr. Vicki Good, AACN's Chief Clinical Officer, and I'm joined by my colleague, Andrea Schmidt, one of AACN's Clinical Practice Specialists.
Hi, welcome to today's episode.
I am super excited for today's episode for a couple of reasons. One, the episode really represents a bit of coming home for me because our guest and I used to work together about 25 plus years ago. We'll just leave it at that. And second, before I entered into my leadership career in critical care, I wanted to be a flight nurse. But for reasons unbeknownst, I changed that and went into nursing leadership instead of flight nursing.
Vicki, it's interesting because I also wanted to be a flight nurse at one point in time. Before I became a critical care nurse, I worked in the ER and I would watch the flight nurses come in and pick up our patients. And I was like, take me with you, take me with you. And my mind loved the idea and I loved the adrenaline, but my physical body, not so much. And so motion sickness was not my friend. And so that one ride I had, that was it. So anyway, our guest, Cindy Goodrich, has been a flight nurse for over 30 years in the Pacific Northwest. And that's actually where the 911 system was started. And within those 30 years, I can only imagine all of the changes, the challenges, et cetera, that she's experienced. So welcome, Cindy, and can you please tell our listeners about yourself and your nursing journey?
Yeah, my journey started way back when as a microbiologist. And I was in school and I thought, what else could I do? Because I found being in a lab a little bit boring. And so I went into nursing. I started my career in the PICU as a new grad. Moved on to coronary care at Parkland in Dallas, Texas, moved to Seattle, practiced as a critical care CNS at Harborview Medical Center, and did meet the flight nurses, and Dr. Michael Kopas was their director, and he encouraged me to come to airlift. And so after being at Harborview for about 8 years, I transitioned over to being a flight nurse. And I practiced as a flight nurse for about 10 years, and then I took on the education position as well. And so currently I fly both and teach, which is a great combination. So I love being able to do that.
So Cindy, what made you decide to become a flight nurse? And what are the basic requirements to become a flight nurse?
The basic requirements, I'll do that first. It really involves, well, in my program, you have to have at least 5 years of critical care or emergency department experience. When I talk with folks, I suggest that they have a lot more than that because we really practice medicine at altitude, as I say. We work with loose protocols, but it's really your past experience that provides the foundation for what we do in the air. And so I think having a really good mix of critical care, especially having a cardiac background where rhythms are easy for you. You've managed patients who are septic, who are in cardiogenic shock with lots and lots of different drips. And then a little bit of emergency department experience is good as well because they really don't have all the technology we have in the ICU. They really are dependent upon their ability to physically assess the patient. And those are a really good combination. Now, we do have nurses with 5 years of experience, and the issue occurs here is sometimes they don't have the experience to fall back on when they get in a situation that's relatively new. Because I transport patients anywhere from someone who has a finger amputation to a patient that I just did over the weekend who was bleeding to death from hemorrhagic shock due to a motor vehicle crash. And so it runs the entire gamut during our shifts. I think I wanted to be a flight nurse when I saw and talked with people at Airlift, which is where I work now. They would come in as a CNS, I would talk with them and they were like, oh, this is really a cool job. We get to do all these things. And I was looking for something that was a little bit more challenging. And to be honest, I really missed the bedside. I missed interacting with patients. And I did it as a critical care CNS, but it wasn't really the same. And so I moved over and it's been a great experience, something that I'm very, very happy I did.
So I know you mentioned, the experience, whether it's, 5 or more years, whether critical care or ED or maybe even ED. Are there specific technical skills that a nurse should maybe have some experience with before they get involved? And then also, how do you address, age populations? So if you're an adult nurse, that's only been all of your experience, how do you learn that pediatric or neonatal type role?
Okay, let me answer the second part first, is that we really transport anyone who has gone home from the hospital after being born, so a newborn baby, all the way to someone who could be 100 years old. And so we have a pretty robust training program where we put the adult nurses into the pediatric population. We'll do clinicals. We'll spend time in the OR at our children's hospital doing intubations and things like that. And then for the pediatric nurses who come to us, they'll do adult clinicals. But it is quite challenging because I've done adults my entire career other than for 2 years where I worked in the PICU. So for me, I'm very happy that we have a great pediatric medical director, that we have great protocols to practice on, that I can pull those up when I'm transporting someone of a small age. Teenagers are easy. It's the little ones that are going to be the challenge.
I'm sure that flight nursing is just like critical care. There's kind of CV nursing, there's, trauma nursing, all those different things. So what are the different areas within flight nursing?
Well, unfortunately, there are none. It's the entire gamut. We've started doing ECMO and doing balloon pumps and Impellas, and it's the entire spectrum, other than we used to do isolates with the babies. So babies that were just born, newborns, where we had an isolate, which was really a rolling incubator that we would take care of the babies. And we now have partnered with our children's hospitals and they're doing those. But other than that, we do everything. I mean, I do trauma. I pick people up off the freeway. I'll go into a hospital, pick someone up out of the ER. Over the weekend, I pick someone up out of the cath lab at one of the hospitals. So it's really, you have no idea what's coming or where you're going, other than a quick report when the pager goes off, and that's it.
Yeah. I mean, it's just so dynamic. But this is the part that always kind of is confusing. What's the difference between a fixed wing transport and a helicopter transport? Or are they just one and the same and it's distance related?
They're really very different. The helicopter, that's what I fly. I fly rotary. And at the beginning of my career, we did fixed wing as well, but now we have designated bases. So I work at a base where I just do rotary. Rotary is split second decision making. It's landing on a freeway. It's taking care of a trauma who's bleeding to death, or, going into a hospital where someone's in septic shock or whatnot. It's a limited period of time. So I might spend maybe 45 minutes to an hour and a half. If I go over to Eastern Washington, it might be a little bit longer. Fixed wing is a little bit more challenging because it's more like a flying ICU, because you could be with a patient for 2 to 3 hours. And so it's not just the initial care, it's that ongoing care. So I think it's a little bit different in that capacity, and distance also plays a role.
So I have a question in regards to if somebody wants to be a flight nurse and they have a strong interest in it. Can you talk about, the regional differences across the country? Because I'm sure that if you live in a very rural area, you may be doing a lot more seeing where there's not a lot of hospitals, versus if you're in a very urban area. Like, for example, I live outside Chicago. We have hospitals every few miles and many, many trauma centers and many ALS ambulances. And so while there are probably some freeway landings, there's a lot more inter-hospital transport. So I'm curious, if you live in the mountains or you live somewhere, how does that look?
It really varies across the country, as you said, geographically. So in my program, we fly probably 30% scene calls and 60% interfacility, or maybe even a more interfacility. So it's going to depend. And a lot of programs that are in the rural areas who fly a lot of pre-hospital, they fly with a medic and a nurse. So the configuration of the team can vary. I fly nurse, which I'm so appreciative of because my partner has a nurse brain. And he or she knows, we've been trained the same. Whereas medics are trained a little bit different. And some programs will even fly with a physician or a nurse practitioner or a resident. And so it really depends. I advise people when they're looking for a program is think about what you want to do and then find a program that meets those requirements. Do you want to fly with a physician or a PA or a nurse practitioner or a medic? Some even fly with a respiratory therapist, or do you want to fly with a nurse? It's all going to depend. And then a lot of it depends on, do you want to move? Do you want to move from where you've been working and go to a different place? Most people want to stay, unless they're single and they're able to move, they pretty much stay where they're working. So there's a lot of variability. And I suggest that people just investigate, talk with people from the program and ask them about, what's it like? What kind of patients do you see? What's your team makeup? Are there RTs? Are there nurses? Are there PAs? Physicians? Those kind of things.
So then my second part of my question is, obviously there's geographic differences, but is there a predominant patient type that you're caring for, maybe just in your area, that you see most often?
Boy, that's a loaded question because it really varies by season. The summertime, as you know, is trauma season. And people do crazy things from almost any type of vehicle, any type of surface. You can get falls from all sorts of things. And you can get motor vehicle crashes or ATV crashes or car versus pedestrian. It's the whole gamut with trauma. We also see a lot of strokes these days. I think maybe it's because we're getting better at identifying them and treating those patients. I was surprised that we don't do as much cardiac as I once did in the program. It's just sort of switched over. And I think part of that is because hospitals are getting better at taking care of cardiac. There's more centers that are doing cardiac cath. There are more centers that are doing open heart surgery or balloon pumps or Impellas. And so there's not the need to transport, whereas trauma, you always need to go to the level 1. And so there's always going to be that need with that. So it's going to be variable. If you were, say, in a big city, say in Chicago, depending, because you have a lot of programs in Chicago, Philadelphia and Pittsburgh or other big areas, a lot of their transports are within the city due to traffic. And so again, it could be the whole gamut. So I can't pinpoint any one type of patient other than the summer, although it's moving into the winter now, is trauma season. It seems to be all year long. And then throw in a little bit of pneumonia in the wintertime and a little bit of COVID and RSV with the kids in the fall and the winter months.
So I can only imagine the advances in flight nursing, because I know what the advances have been in just in hospital nursing in the time that we both started our careers. So talk about some of the advancements that you've seen in the flight nursing.
Okay, advances. Well, airway management has definitely come a long way from just doing direct laryngoscope, doing DL versus now we're doing video laryngoscopy, where we have a laryngoscope blade that has a camera on it where we can see during intubation, which has really, it's been a game changer because we're able to intubate so much easier and quicker in the field. So that's a huge advance. The other thing is this ultrasound has moved into the pre-hospital environment. We're using Butterfly now. And so we can ultrasound doing fast tests, looking for bleeding in the abdominal compartment. We can do a cardiac exam. All those sorts of things are moving into it. But a lot of it's the basics. I mean, you manage a septic patient with fluids and with pressors. The drugs have changed a little bit. And then The other thing I would say is cardiac devices have now come into the field where we have a team that will go to another hospital and cannulate an ECMO patient, and then we'll transport them. Or we'll transport someone who's already on ECMO. Or we'll go to the cath lab and get someone who just had a balloon pump or an Impella put on. So those have moved into ours. But a lot of it's just the basics. It's your A, B, C's, and D's. Like we've all learned, except now, X is before ABC, where we're really focusing on massive hemorrhage control first.
Mhm. Well, and I just recall like simple things like even IV pumps. Used to we couldn't use an IV pump even in the back of an ambulance because just the shaking there. But now they've been able to stabilize those devices to be able to be used in transport.
Yeah, we use small pumps that are nice, but sometimes if you have someone who's septic and they're on 10 drips, it's sort of like a juggling act. It's almost comical with all the equipment we have on. I do have a bedside to bedside ventilator that I take in. So I'll take the ventilator in if the patient's on a vent, put them on our vent, and then we transport them from the time we put them on it to the time we drop them off on the vent. So that could be considered an advance as well. And ventilators have gotten much more portable and much more sophisticated, and I would say easier to use because we manage the vent without an RT. So that was something that is new for most nurses coming into flight nursing. That is new because we're usually not allowed to touch the vent in the ICU.
I remember those.
Oh, yes. You get your hand slapped.
Oh, yeah. And now I'm
Touch the
responsible for it.
Right. So let's shift a bit and discuss what does a day in the life of a flight nurse look like? And, just sort of from what you do when you get there till when you go home, how long is a shift? And then are there any particular safety things that you're dealing with that a regular nurse in a hospital is not even having to address?
All right, let me go through the day, and then you may have to remind me of the safety piece if I forget it, which is
Sure.
really important. I definitely want to touch on that. So generally we work 9 a.m. to 9 a.m. So they're 24-hour shifts. We go to the base and we're like firefighters. We stay at the base, but we don't have an ambulance or a fire engine that we can take down the street to Starbucks. So we pretty much are at base the entire time. So when I arrive at work, I'm in my flight suit and we do an exchange with the off-going shift. We carry blood products. So we talk about the blood, how many hours are on it. We check our narcotics, talk about any equipment malfunctions or things that need to be put back in the aircraft. We'll go out and check the aircraft. We carry our jump bags that have medications and equipment and all sorts of things. And then we check those every day. So we'll go check those, my partner and I. We'll go back in and then we do a brief with all the bases and our communication center. And then we have an administrator on call that will run the meeting, and they just go through who's at what base, what helicopters or planes are in service, any maintenance type issues, and anything else. We also talk about a safety topic, which can run the gamut. And then there are clinical topics. After that meeting, and during this entire time, from the time I get there, we're waiting for a call. So if a call comes in, we just go, and all this other stuff goes by the wayside. And then it's really just waiting throughout the day for the pager to go off. If the pager hasn't gone off, we have tons of online training like everyone else that we have to do. And we go through our flights. On the flight, we take care of the patient. When we get back, there's a fair amount of charting we have to do. And then we just wait for the next call. And so we're lucky in that you can take rest breaks when you're not flying. So we take safety naps, as they call them, to make sure that we're ready for the next patient. So let me touch on safety really quick. I think that was the second part, which is it's one of the pillars. It's probably the most important thing that we do because everyone needs to come home at the end of the shift. Mm-hmm. And so I fly with one pilot in the helicopter and there's 2 nurses. And so we have a robust safety program. We talk about safety every day. Think about when you're around an aircraft, especially on a helicopter, there are rotor blades. There's the tail rotor. There's all sorts of things that you need to be careful around. So our pilots are very vigilant to make sure that we're safe. I have to get in the helicopter. I put on my helmet because we wear helmets. We have communication between all the members that are in the helicopter through our helmets. You have to get in your seatbelt. You have to watch for traffic. So we're always helping our pilot look for traffic outside the window. So again, it's not only nursing, but we have a huge part in aviation that we play. And so we learn about the radios and how to do those and emergency procedures. So it's a lot of extra stuff that in the hospital, we don't really do that kind of safety. In the hospital, it's more safety with chemicals and other things that we're dealing with, patient safety, those kind of things.
Right. It's very interesting. How many calls a day, roughly, on average, would you have?
It can depend. It can be where you get completely shut out and there are no calls, or to the point, I think my most, and this was many years ago, was 8, which is incredibly challenging because sometimes they happen in rapid succession. We also have a very strong fatigue program where if you do so many flights or so many flights that are difficult for you, you can tap out for a 4-hour period of time and rest and recover and then go back into service. So it really varies. And, sometimes you'll have a really bad call where there's the death, especially of a pediatric patient, all those kind of things. And people may tap out for a short period of time to recover. So the moral and ethical stress that occurs in flight and the types of patients that we take care of as well is just like what we have in the ICU. It's all those moral dilemmas, except we see more patients. And so I see more tragedy in every day versus in the ICU, I would take care of 1 or 2 patients. Now I have many patients that I'm taking care of. So a little bit of a different stress.
Cindy, on that aspect, who makes that final decision as to whether or not you're going to fly to a scene?
So it's 3 to go, 1 to say no is the mantra. And so if we're going out to a scene, and because we've had a lot of smoke here in Washington and we get a lot of fog, we're going into the really difficult time of year where the weather is incredibly unpredictable. And most of the time we fly by VFR, which is visual, so the pilot can see the ground. In the wintertime, or when there's lots of clouds, we fly instruments, which is like what the commercial airlines do. And so it becomes much more challenging. And then take into consideration the geography. We have tons of mountains. We go over lots of water. And so, it really has to be all 3. If someone's not feeling well and they get up in the aircraft and all of a sudden they're just not feeling well, they can say, turn around. If we're flying into fog or into weather and one of us feels uncomfortable, you just get the willies about that, we can say we need to turn around. And that is always something in flight that is well accepted.
Yeah, I'm always amazed at the teamwork and the crew resource management that, the flight crews use. And it really is that whole thing of one person speaks up and their word is equally as important as anybody's. So it's a great environment regarding that.
It is. And my team, my partner and my pilot are my lifeline for 24 hours. I am dependent upon them to go home. And so you really do, it's like a family. It's very different because we're thrown into these really stressful situations. I mean, my partner and I could be in the back of a medic rig with someone who's bleeding to death, who needs to be intubated, who doesn't have any IVs, who needs blood products. And it's us and maybe 2 medics. And maybe I have an EMT. Or maybe we go to a scene and we're the first responders and we're doing all of that. I've been called up into the mountains for hang gliding accidents where there are just BLS providers that all they can do is pretty much put a sat probe on the finger, open the airway, and that's about it, and do CPR if they need to. And so when we arrive, we need to do everything. And so it's really going to vary. But again, my partner and my pilot are my lifelines for 24 hours.
Yeah. So talk a little bit more. You talked some about the autonomy, but talk a little bit about that. How do you make those decisions for the moment? Somebody needs a chest tube or you need to take some kind of invasive action in the air. What's that
This is,
decision making like?
yeah, this is where your past experience, and again, this is why, even though it says 5 years to get in, I suggest that people go back and get more, unless they've worked, maybe if you worked in a Harborview type situation where it was a level 1 trauma center, where every day you saw tons of stuff. But if you're in a smaller hospital, you're not going to gain the same experience. And so we have protocols. So we have clinical practice guidelines, as they're called. And there would be, say, one for a trauma patient that says, these are the things you're going to do as far as your ABCs, taking care of massive hemorrhage, what you're going to do. We carry quick clot, we carry tourniquets, we sheet pelvises, we give blood products, we give TXA. There are all sorts of things we do. So the protocols have those written down as suggestions or things to do. But it's really up to us to implement those and to practice within those guidelines. If it's in a facility, say I'm with a really sick septic patient or a really sick neuro patient, I can call my boss, my medical control, or one of the attendings and get advice on what to do. But really, I mean, if a patient codes, you can't pull out your ACLS cards and say, okay, start at the top. So we drill a lot, we practice a lot, because you need to be able to react split second. And for a lot of people, they don't want that autonomy. They're happy to work in an environment where they have lots of support. And we've had nurses come to us that started with us. And once they saw the responsibility and the autonomy you needed, they said, this is not for me. I need to go back into the ICU. And that's perfectly fine. Everybody has a space. I would not be a good clinic nurse because I'm an adrenaline junkie, and it would be just too slow pace for me. So something for everyone.
I want to piggyback onto something that, Vicki had asked when it comes to autonomy and the skills. Are there additional skills, such as, do you put in chest tubes? Do you learn to, put in a central line if there's no physician flying with you?
We don't do either of those skills. So the skills that we do that are kind of advanced, and really, it's really targeted at that initial treatment of a patient that's getting ready to die, or sort of in that pre-code type situation. So we intubate, we can put in needles into the chest, so do needle decompression for a tension pneumo, which would be a medical emergency. We're in the process of training the staff to do finger thoracotomy. So like a chest tube, you're just making a hole in the chest, letting all the air and blood out, but we don't physically put in chest tubes because most of our flights are not long enough. We don't put in central lines, but I put in a lot of IOs because IOs are much quicker than doing a central line. It makes a big difference with that. I'm trying to think what else we do. I think that's pretty much, but I manage hypotension based on, I have protocols, but then I have my way that I would manage a septic patient who is hypotensive, or those kind of things as well. We carry blood products, which is nice. So we administer blood. And then some of us, and I'm considered one of the SWAT nurses, I do ultrasound as well, but not all our staff are doing that.
It's fascinating.
Yeah, and with that fascination comes a lot of stress, I'm sure. And for you to have been doing this for 30 years takes clearly a special individual. So talk to us about how you handle that stress. And I understand that you might have a unique way to handle it.
I'm a big physical type person. So years ago, I started bodybuilding. And so I was a bodybuilder for about 10 years. I became a pro bodybuilder, and then I switched over to powerlifting. And I'm currently powerlifting. We're training for a world meet in Seoul in December. And so for me to go to the gym and lift heavy things is the stress reducer, because when my coach is yelling at me to deadlift or to squat, I can think of nothing else other than what I'm doing. And I think it's a really good stress reducer that a lot of people just don't think about. But it is amazing because, again, when you're in the gym or when you're riding your bike or walking or whatever, a lot of times you don't have time to think about anything else and everything else goes away. And it really helps me to focus myself and then come back and be able to go to work and be the best nurse that I can be.
That's amazing. And for our listeners that don't know Cindy, she's a very petite individual. So I can only imagine how much weight you're lifting, which is probably what, 3 or 4 times your body weight would be my guess.
Yep, it can be. And yeah, it's a great, I lift with a team of ladies. There's one guy and 4 of us ladies, and it is just a wonderful, we've traveled the world. I've been to Mongolia and Sweden and South Africa and soon to go to Seoul.
Wow.
So it's a great experience. I suggest that people find a passion outside of work and to follow that dream, because it is just amazing to get your head out of work all the time.
I think it's so important, because if you take every single thing you've seen, smelled, heard, the tragedy, I think, you could make yourself so utterly depressed and make you not want to go to work. So I think really finding something is just amazing, finding something to do. And I'm very impressed that you're powerlifting. That is very cool. And I have one last question before we draw to a close. And I don't think that we addressed this at all. So some people would find this stressful. I know I would. If somebody's very interested in flight, they get up in there and they realize, oh, maybe I have motion sickness, or they're not sure how they feel about the air. Do you eventually get used to it, or how do you manage stuff like that? Because that ill feeling can definitely cause stress.
I think that in that case, if I was someone who had motion sickness, that I would try to do a ride along with a flight program and just check it out, because I'm going to tell you that I don't think it ever goes away unless you were willing to wear a patch with a motion sickness. People who are afraid to fly, it's not going to go away. I mean, we've had people who have come in who tried it and it just didn't work for them. And I can't imagine going to work every day and being afraid to get in the aircraft or feeling like I was going to get sick every time. Now, there are days when there's tremendous turbulence and everybody feels bad. And that's normal. But on a regular day, so trying it out, if you have problems on commercial flights, then you're probably not going to have good success with flight. And there's so many things we can do in nursing. My gosh, it doesn't have to be flight nursing. There's so many different avenues. Work in the cath lab, work with babies, work with pregnant ladies, lots and lots of options. So people shouldn't feel that they have to do something that makes them feel sick or uncomfortable.
Oh, and there's even ground transport too.
There's totally ground, but people who generally get motion sickness,
Oh,
the ambulance, because we've had nurses as well, and they turn green and I feel so bad for them. I'm like, oh my gosh, I don't know what I can do for you. I can give you some Zofran, but that's about it.
As we draw our conversation to close, what is one piece of advice that you would give a nurse starting his or her career that you wish you were given?
Wow. I don't know, because I tell you what, I was blessed that my path was so awesome that I would just focus on a goal and find a way to meet it and get into it. And so I guess my advice is have an idea of what you want to do, and then think about what are the steps I need to do to get there. And then once you get there, think about, is there something else I want to do? Because it's really a stepping stone. I think your career has been the same way. We all start at the bedside, start in an area we're interested in. And if you're in an area that you don't like, get out and go to a different area. Don't suffer. Don't say, I'm just going to get this out because, if you don't want to take care of trauma because of the mess of the blood and whatnot, then try another area, maybe, pediatrics or obstetrics or something else. But I think set a goal and move towards it, because there's so much opportunity in nursing, so much.
Well, this has been just amazing to talk through this with you, and your career has been extremely impressive, and And for our listeners, Cindy's often a very frequent presenter at NTI and brings her insights to our NTI audience as well. So on behalf of all of the lives that you have touched and you've saved through the years, thank you, because you've had just a remarkable career and we appreciate that. And thank you for spending this time with us, because I know your time is highly valuable.
Thank you so much. It was a wonderful opportunity. I really appreciate the time to share my experiences, and I hope that there are some future flight nurses out there that are getting excited about starting their journey. So good luck.
Well, thank you also to our listeners for joining us on this episode. We'd love your feedback on this episode and any ideas for future episodes. Please send your feedback to podcast@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's Career Center, offering career resources, free resume reviews, and personalized job alerts, with information available at www.aacn.org/career center.